friends, welcome to the session. Now we'll continue with the second part. We already have discussed about antiarrhythmic drugs. We have discussed what are the various mechanisms by which arrhythmias occur. We have discussed how we classify the drugs which are useful in arrhythmias. What are the different mechanisms by which they act. We talked about Vaughan-Williams-Singh classification. We have already covered class 1 agents, all the three subcategories or subclasses, class 1A, class 1B and class 1C. Now continuing further, we start with class 2 agents. The class 2 agents, they are basically anti-adrenergic drugs, that is beta blockers. They have additional effects. We know that those which have ISA, that is intrinsic sympathomimetic activity, that is they will produce a relatively lesser reduction in the heart rate. Drug like propranolol, it also, in addition to having class 2 activity, also has a class 1 activity. We know that propranolol has local anesthetic like activity, and you are aware that local anesthetic activity occurs by the blockage of sodium channel. We have drugs like sotalol, which are also beta blockers, which in addition to having a class 2 activity have a class 3 activity and are a distinct member of this class 3 antiarrhythmic agents. So coming first to beta blockers, they increase the effective refractory period, they decrease the conduction velocity, which is responsible for their antiarrhythmic activity. On the His-Purkinje fiber, they decrease automaticity and they affect early after depolarization and delayed after depolarization induced arrhythmias. They increase the PR interval, they also decrease QT interval, and therefore they are used in QT prolongation syndrome. Any other drug which is used in QT prolongation syndrome, we already have seen that class 1B agents and beta blockers now, they are the two agents which can be used in torsades de pointes, whereas class 1 agents and class 1C agents, they are contraindicated in patients with torsades de pointes. So where are beta blockers used as antidysrhythmic agents? They are used in paroxysmal atrial tachycardia, which is associated with emotions or exercise. We prefer to use a short acting agent like esmolol because these are transient events. Giving a beta blocker at the earliest possible time is able to abort these events. They can be used in thyrotoxicosis associated atrial fibrillation. They can be used in ventricular arrhythmias associated with exercise. They can be used in congenitally prolonged QT syndrome. They can be used in patients who are having arrhythmias associated with acute myocardial infarction. As mentioned earlier, in acute myocardial infarction arrhythmias, we have to use lidocaine because it is relatively safer. But if we use a propranolol, remember propranolol is a beta blocker, or we use any other beta blocker will be decreasing the heart rate and can produce hemodynamic instability. So use it very cautiously in patients who have acute myocardial infarction. Use at a low dose which is possible. It also results in control of inappropriate or unwanted sinus tachycardia. We already are aware of use of beta blockers for this indication. It can be used in ventricular arrhythmias which are associated with pheochromocytoma. But remember, in pheochromocytoma, we have to use combined alpha and beta blocker. Otherwise, there will be uncontrolled increase in the blood pressure and heart rate. So though you have a tachycardia which is associated with pheochromocytoma, the preferred drug is beta blocker, but because it is pheochromocytoma, so therefore you have to use a alpha blocker along with, or use labetalol, which is a combined alpha and beta blocker. Now then we come on to the class 3 agents. Class 3 agent I have already talked to you about, that this includes a beta blocker, that is sotalol. In addition to this, other agents like amiodarone, beryllium, dofetilide and ibutylide are the other members which are there. These are the drugs which are acting by potassium channel blocking activity. So just revise, class 1 agents, they are acting by sodium channel blocking activity. Class 2 agents, they are acting by beta blocking activity. Class 3 agents, they are acting by potassium channel blocking activity. Class 4, they are acting by calcium channel blocking activity. Among these, amiodarone is very important. It is a very important drug for getting short note as well as getting a question in MCQs over here. Amiodarone is a drug which is having structural similarity to thyroid hormone. It has high lipid solubility and high tissue solubility, therefore it has a slow elimination, meaning thereby it has a long half-life. It, in addition to having class 3 activity, also has class 1, class 2 and class 4 activity. It is attributing a decrease in potassium efflux Because of this, it is classified as class 3 agent. It can have some degree of sodium channel blocking activity, therefore it is also classified as class 1 agent. It also decreases calcium influx, therefore it has class 4 activity, and it is having a non-competitive alpha blocking activity, therefore it also has class 2 activity. So this is one drug which has all the 4 classes of antiarrhythmic activity, and it is a preferred drug for number of indications which are there as a dysrhythmic agent. It rarely produces Torsades de Pointes. It has a boral bioavailability of just 30%. It has a very high plasma protein binding, a large volume of distribution of 66 liter per kg, meaning that it is getting accumulated in the body. It has a slow hepatic metabolism, and I mentioned it has a very long half-life. Now remember, what is an arrhythmia? Arrhythmia is a transient or a sudden increase or decrease in the heart rate. And how do you require the drugs which are useful in arrhythmias? Do you require the drugs which have a longer half-life, which have a longer latent period, or you want the drugs which have a shorter half-life or which have a shorter latent period? Obviously, as I mentioned, that when we have arrhythmias, there is a hemodynamic instability, and these arrhythmias can be fatal. Therefore, you require drugs which have an early onset of action. So how do we convert a drug which is having a long half-life with an early onset of action? We give a loading dose. Therefore, when we give a loading dose, a very high plasma concentration is achieved and the therapeutic effect starts effectively. Therefore, one must be giving a loading dose which is then followed by a maintenance dose for this drug. What are the uses? It is useful in recurrent ventricular tachycardia or ventricular fibrillation. It is useful in paroxysmal ventricular tachycardia or ventricular fibrillation. It is also useful in post-myocardial infarction arrhythmias, and is also useful in arrhythmias which are associated with congestive cardiac failure. So when we talk about post-myocardial infarction arrhythmias, the first agent which is very safe can be used is lidocaine. The second agent which can be used very effectively is amiodarone. And the third agent which can be used are beta blockers, but again beta blockers should be used cautiously because they can cause hemodynamic instability in patients with acute myocardial infarction associated arrhythmias. The ADRs which are associated, they include hypotension and nausea. Because it is a drug which is having a long half-life, it gets accumulated in the body, having a high plasma protein binding, most ADRs are dose and duration related on chronic use. The most important ADR to remember is that it is having a structural similarity to thyroid hormone. It can produce both hypothyroidism and hyperthyroidism. So therefore, those patients who are on amiodarone, they need to be monitored long term for thyroid function tests. It can cause pulmonary fibrosis, can cause corneal microdeposits, can cause hepatic dysfunction, peripheral neuropathy, and even photosensitivity. Another agent with class 3 activity is beryllium. It is adrenergic neuron blocking agent. Initially, it causes increase in norepinephrine release followed by decrease in norepinephrine release. It means it can cause increase in blood pressure, which is then followed by a decrease in blood pressure. It increases action potential duration in His Purkinje fibers. It does not produce any depression of conduction as such. The major limitations are again a lag period. This lag period is up to 2 hours even after IV injection. Any other drug which also has a lag period when given intravenously? It is phenoxybenzamine, which is a alpha blocker. Even when given IV, it has a lag period, and beryllium also has a lag period even on giving IV injection. Remember, the conventional is that if you give IV, the effect starts immediately, but this rule does not apply in case of beryllium as well as in phenoxybenzamine. It also carries a risk of producing arrhythmia and increase in blood pressure, and this is mainly because of initial increase in norepinephrine that we talked about. This is because of the catecholamine associated increase in blood pressure. Its use is in post-infarction serous ventricular arrhythmias, in recurrent or refractory ventricular tachycardia, ventricular fibrillation, and ventricular ectopics. The ADRs are transient increase and then followed by fall in blood pressure. This I've already explained because it causes increase in norepinephrine release, which is then followed by decrease in norepinephrine release. There is a risk of arrhythmias. There is risk of swelling and tenderness of parotid gland. This is a very classical effect which is seen with beryllium. It is very commonly asked in MCQs as well as in Viva OC examination. Another member of this group is dofetilide. Dofetilide prolongs action potential duration and effective refractory period. There is no autonomic or peripheral effects which is there. It is a pure class 3 agent. Its use is to convert atrial fibrillation or atrial flutter to sinus rhythm. It is more effective in maintaining normal sinus rhythm in converted subjects. What are the other drugs which are useful in maintaining normal sinus rhythm after giving electrocardioversion? It is class 1A agents. Lastly, we have the class 4 agent, that is calcium channel blockers. So these include members verapamil and diltiazem. They have major antidysrhythmic effect, and these effects are mainly because of AV blockade. You need to remember what are the other drugs which produce AV blockade. These include digitalis, beta blockers, and the calcium channel blockers that we are talking about, verapamil, and diltiazem. They are useful in paroxysmal supraventricular tachycardia, atrial flutter, and atrial fibrillation. The major ADR associated are it can produce congestive cardiac failure, AV block, sinus arrest, and also cause fall in blood pressure. They can cause constipation and also peripheral edema. Now with this we have finished with the antiarrhythmic drugs which are classified in Vaughan-Williams-Singh classification. There are other drugs which also have antiarrhythmic activity, but they are not classified over here, and they are also important. Coming to first of these agents, that is adenosine. Adenosine acts on adenosine receptors A1 or purinergic receptors P1, which mean the same. There are different ways of classifying over here. They produce acetylcholine-like effect. They produce hyperpolarization, which decreases spontaneous diastolic depolarization and increase action potential duration. They have verapamil-like effects because they produce AV block and also produce reduction in delayed after depolarization. Remember, delayed after depolarizations, they occur from the stimulation in the phase 4.